today's Grand Rounds is special. It is the 27th annual Eli and Mildred Barry Friedman Lectureship. We are so thankful and very happy to have Dr. Kevan Clifford Herold from Yale come to speak to us on the subject of immune therapies to change the course of type 1 diabetes. I just wanted to say a few words about this lectureship, Dr. Friedman and Mildred Friedman. Okay, so who is Eli Friedman? Dr. Friedman was a distinguished teaching professor of medicine at SUNY Downstate from 1963 and retired in 2018. He is a pioneer nephrologist. He invented the suitcase hemodialysis machine right here at Downstate in the 1970s. He started the kidney transplant program at Downstate, and he's published over 500 manuscripts, 12 books. It's just incredible. He's a mentor to many people. He has at least 6 or 7 individuals who can claim they went through him and became either a professor or a chair of a division or a chair of a department in the United States. That is just an amazing accomplishment for someone who has ever walked the halls of SUNY Downstate. This is the first transplant program at SUNY Downstate in 1972. You can see to my very left here, it was the fellow, Dr. Bart, who later became a great transplant surgeon and ran our transplant program for many, many years until he went to Westchester Medical Center. And then this is Dr. Samuel Cones. He was a surgeon who initiated the program in 1972. If you go up to the 8th floor, you see his picture there. It's a masterpiece. He was one of the first transplant surgeons in the country, and of course, one of the first black transplant surgeon in the United States. And he did his transplants at Downstate. Actually, the first televised kidney transplant was done by him at Downstate at that time. And then to the middle here, Dr. Peter Medawar. He actually won the Nobel Prize along with Dr. McFarlane Burnett and with the discovery of the acquired immunological tolerance. That time they did skin grafts between mice, and they were able to show that you can actually induce tolerance, and that discovery led them to the Nobel Prize in 1960. And then Dr. Eli Friedman is right here. Right now, the transplant program has done more than 3,600 kidney transplants. It's one of the very good kidney transplant programs in the country at this time. So we are very thankful for his contributions. And his wife, Mildred, also known as Barry Friedman, of course, that was his wife. She unfortunately had type 1 diabetes and developed diabetic nephropathy. Then she lost her kidneys, was on dialysis, and received a kidney transplant at some point. Kidney transplant worked for at least close to 2 decades. She was a founding member of the American Association of Kidney Patients. This American Association of Kidney Patients was actually founded right here at Downstate by Mildred and others. So she had some very interesting contributions to patients and patient advocacy and patient rights. She was a staunch writer as well. And so the lectureship was created in honor of her and has been going on since 1998. So that ends my presentation. So today we are really honored to have Dr. Herold. He's professor of immunology and internal medicine. He's also the CNH Long Professor of Immunology and Medicine at Yale University, New Haven, Connecticut. His CV is just amazing. What he has done in the field of type 1 diabetes is just amazing. And so please join me in thanking him and welcome him to Downstate. His lecture is going to be by Zoom, but I'm sure it's going to be as effective as in person. So please join me in thanking him and welcome him to Downstate for this lecture.
Thank you all for the honor to give this lecture in honor of Mildred Friedman, Mildred and Eli Friedman. I hope what I will be talking about will kind of be a inspiration for eliminating the disease, frankly, and so that we could view these historical moments as things of the past um, as we move forward. All right, so here are my disclosures. So let me just start it with a bit of a review and point out that the rates of type 1 diabetes continue to increase. This is data from the SEARCH study that has looked at the rates of diabetes in youth in the United States. And the paper that I'm showing here from the New England Journal talked about the increasing rates of type 2 diabetes in children, and I know that you all are very familiar with that. But in addition, the rates of type 1 diabetes have also been increasing. And you can see this from, if you look at the incidence rates from 2003 to 2012. And they continue to increase. Now, the reasons for this I'm not going to go into, but I think that is the topic for another discussion, whether this is related to the hygiene hypothesis, unlikely to be related to just genetics, but potentially other environmental factors that may be contributing. Now, over the past 100 years, there have been tremendous improvements since the discovery of insulin. There have been tremendous improvements in our ability to manage the disease using exogenous insulin. And the problem, though, with this, and look, I can say as someone who sees patients myself as well, I use all these technologies in my patients as well. And these include things like insulin pumps, continuous glucose monitors, and a variety of ways of transmitting and responding to data. In spite of all of this, our ability to manage the disease and the uptake of these technologies in clinical practice is still not meeting goals. So here is data from the Type 1 Diabetes Exchange Group that basically is a collection of centers, many of them academic medical centers, where the only thing that was done is the hemoglobin A1Cs of patients coming into the clinic was measured. And and the target hemoglobin A1C, the ADA standard of care, is an A1C of about 7. And as you can see that we don't come nearly close to achieving that standard of care. It didn't look so good in 2010, and it looked even a little worse in 2016. So in spite of all the technologic improvements, we still don't meet the standards of care, and it's particularly bad for children. You can see if you look under the age of 20, their hemoglobin A1Cs were as bad as they were in 1993, which was the date of the publication of the Diabetes Control and Complications trial that indicated that strict control of glucose could prevent the microvascular complications of the disease. And so these children in particular are at risk for developing complications. Now, it is not without other consequences. There is a loss of life expectancy. And this is data from Scotland, not a third world country, but Scotland, where there was about 11 or a 13-year loss of life expectancy for men and women diagnosed under the age of 20, diagnosed with type 1 diabetes. In other countries around the world, the loss of life expectancy is even worse. Now, my discussion today is going to talk about ways that we might prevent diabetes and change the course of diabetes. So let me just run through a couple of fundamental points about the pathogenesis of the disease. First of all, type 1 diabetes is an autoimmune disease with a metabolic outcome. That's the most important thing that I'm going to say today. TMB lymphocytes are involved in the pathogenesis of the disease, and some of the anatomic data indicates that innate immune cells are also found in the islets and very important in beta cell destruction. We know some of the targets of the immune cells, and there's a number of different targets. They include things like insulin, proinsulin, GAD65, IGRP, and others. The fact that there are multiple targets suggests there must be multiple cells that are involved in the pathogenesis. And as I'm going to explain to you, immune therapies can alter the course of the disease after the diagnosis and even before the diagnosis. So just to reiterate this critical point, type 1 diabetes is an autoimmune disease with a metabolic outcome. It probably is due to the activation of cells that are probably T cells and B cells that present and can recognize autoantigens, some of which I've mentioned to you already, proinsulin, insulin, IGRP, GAD65, and others. And that gradually, if you start on the left side of this slide, there is activation of these cells and loss of insulin-producing beta cells. Over time, the loss of beta cells becomes critical so that metabolic control can no longer be maintained. But the thing that underlies the whole process is shown on the right side. There's basically an imbalance between immune activation and immune regulation, and that's a theme that's going to carry through in all the data I'm going to show you. Now, we can identify individuals who will develop diabetes before the diagnosis of the disease. This becomes critical for trying to prevent its onset, as I'm going to explain. There are antibodies against autoantigens, and they include what's shown on this slide: insulin, which is IAA, GAD65, GADA, IA2, and the zinc transporter on beta cells, ZNT8. And these autoantibodies can be measured clinically. They can be obtained in your clinical lab, and they're available from all commercial vendors as well. But what was very important and moved the field forward is that we know that when individuals have these autoantibodies in their serum, they are progressing to type 1 diabetes. This is old data from the Barbara Davis Diabetes Center that basically showed if you're the relative of a person with type 1 diabetes and you're found to have at least 2 of those biochemical antibodies that I showed you on the previous slide, you are going to progress to diabetes. It's not a question of whether, it's a question of when. You need 2 or more autoantibodies to identify the initiation of the autoimmune process that's leading to the disease. As you can see in this slide, individuals, relatives who are non-diabetic who have a single autoantibody, their rates of progression are very, very slow. In fact, they may never progress to type 1 diabetes. But once 2 or more are present, you are on the course that leads to overt clinical type 1 diabetes. And interestingly, it's not the titer of the autoantibodies, it's the number of different autoantibodies that you recognize. And we can speculate on why that might be, and it probably involves expansion of the targets of the autoimmune response. So in other words, when more targets are recognized, the disease is more robust in its progression. Now, based on these initial observations and other work that went on in studying patients, this model of the progression of type 1 diabetes was developed largely by George Eisenbarth back in the 1980s. And basically what the model is, it's on the left side. And what's shown in this graph is beta cell function on the y-axis and time on the x-axis. That an individual who will develop disease probably starts out with relatively normal beta cell function. Something happens and these autoantibodies appear. We call that stage 1 type 1 diabetes. We know that the risk of developing to clinical diabetes is about 35 to 50% over 5 years. When there's some decline in beta cell function, the rates of progression are much faster. We call that stage 2 diabetes, and the risk of diabetes is 75% in the next 5 years, or 50% in the next 2 years. Stage 3 is what walks in the emergency room. And unfortunately, many people in the United States still present with diabetic ketoacidosis. Stage 4 is what follows after the diagnosis and generally leads to complete or near complete beta cell loss. Now, one of the points I want to make about this, and these observations have been replicated around the world. This is data from Bavaria, from Germany. But one of the points that I think is very interesting from this study of Annette Ziegler's in Bavaria is that the rules that apply to the relatives of patients with type 1 diabetes apply to the general population as well. On the left side, what was done is Dr. Ziegler screened nearly 100,000 children who were born in age 2 to 5 years, and they found a number of individuals who were autoantibody positive who did not have relatives with type 1 diabetes. And what she is showing here is the rate of progression to clinical diabetes in those who were found to have 2 or more positive autoantibodies. It's about the same as on the right side, the progression in the relatives of patients with type 1 diabetes who have these same autoantibodies. So the reason I want to show you this is when we get to the end of the trial, I want to suggest to you that we're in a new place in screening for type 1 diabetes, and it may be time to think about screening the general public. Why should we screen? Well, basically, there are a number of reasons. Number one, we know that by screening, we can reduce the rates of diabetic ketoacidosis. And I would point out to you that there are still children who are dying of diabetic ketoacidosis. It's also interestingly been shown that screening can reduce the hemoglobin A1C by about 0.1% over a patient's lifetime. And then, as I'm going to talk about, there's access to preventative therapies. So I want to run through a number of studies that have gone on to show how immune therapies can change the course of type 1 diabetes in individuals who already are diagnosed with the disease. Now, I'm going to just declare up front that I'm biased about this because the studies I'm going to show you have been done by TrialNet. Now, I'm the chair of TrialNet. TrialNet is a NIH-supported consortium that is involved in screening individuals who are at risk for type 1 diabetes, largely family members, to identify ways of preventing the progression of the disease. So I'm going to show you the work that's gone on over the past little over a decade by TrialNet. So first of all, targeting B cells, B lymphocytes, seems to change the course of type 1 diabetes. On the left side is a paper published a little over a decade ago that basically showed with the antibody that we know very well, rituximab, we could change the course of type 1 diabetes. The panel on the left shows you C-peptide responses in patients at the time of diagnosis, treated with rituximab at the time of diagnosis, and we're looking at C-peptide responses. It's better in the rituximab compared to the control group. Patients got 4 doses of rituximab at the time of diagnosis. The problem with this was when B cells were covered, the C-peptide continued to decline. And the other thing that's problematic about this, in the data shown on the right side, which is from Eric Meffrey, autoreactive B cells that were present before the rituximab was given return after the rituximab was given. In other words, this was not a permanent reversal of diabetes. CTLA-4 Ig that's used for treating rheumatoid arthritis and other diseases also had an effect on changing the course of type 1 diabetes. CTLA-4 binds to B7-1 and B7-2 and prevents the activation of T cells. And preclinical data from the NOD mouse model suggested it would prevent the development of type 1 diabetes. On the left side, I'm showing you data from patients with new onset disease, and you can see the blue line, the treated patients, have improvement in their C-peptide responses, shown on the y-axis. The right side shows a prevention trial where we took those who had 2 positive autoantibodies, and we looked at whether it would prevent to dysglycemia. And the answer was there was a biologic effect, but it was not statistically different. We'll come back to that later on. ATG, anti-thymocyte globulin, given to patients with new onset type 1 diabetes, had a beneficial effect on C-peptide responses, shown on the right side. We're looking at C-peptide in individuals treated with 2 days of anti-thymocyte globulin, a relatively low dose in blue, compared to placebo in red, and then some of the patients also got GCSF. That was not effective and didn't improve the responses of ATG. But nonetheless, the C-peptide responses 2 years after the single 2-day course of ATG were significantly better at the end of 2 years. Elefacep, LFA3 Ig, another drug that targets T lymphocytes, had a beneficial effect on C-peptide responses. This graph on the left side shows you C-peptide responses in people who got 2 courses of Elefacep, LFA3 Ig, And we're looking at responses out to 2 years. You can see the C-peptide responses in the drug-treated people in red are significantly better. On the right side is what I think is a clinically important take-home message from this. If you improve C-peptide responses, in addition to potentially improving hemoglobin A1C and reducing the requirements for exogenous insulin, you also, this study showed that you also improved the frequency of severe hypoglycemia. Shown in the the frequency of these events are shown in the drug-treated people in red compared to placebo in blue. Now, hypoglycemia, particularly severe hypoglycemia, is the limiting factor for our ability to treat type 1 diabetes. If hypoglycemia was never an issue, we could give tons of insulin with no risk. But of course, insulin induces hypoglycemia, which is frequent, can be severe, can lead to loss of life, and is the limiting factor for how we go about treating type 1 diabetes. By preserving your endogenous beta cell function, you are able to reduce the dependence on exogenous insulin and the risk of severe hypoglycemia, which is shown on the right slide. Now, another agent, golimumab, an anti-TNF antibody, was also shown to preserve beta cell function, which is shown on the top, and the insulin use was reduced, shown on the bottom. This is a paper published a couple of years ago in the New England Journal. So a number of different agents in targeting T cells and inflammatory cells seem to change the course of diabetes. But let me just point out another player in this whole dance, which is beta cells. Remember, this is a dynamic between immune cells and beta cells. And the question is, what do the beta cells have to do with this? And work from my lab and many other labs have suggested there is a dynamic relationship between beta cells and immune cells, such that when an immune cell recognizes an antigen on beta cells, it makes a number of inflammatory cytokines that then lead to a number of changes in beta cells, including expression of this molecule, TET2, production of cytokines by beta cells that enhance the activity of immune cells that then go on to kill beta cells. So in other words, there's some choreography between beta cells and immune cells, and the question is, if we stop that, can we change the course of diabetes? And the way that one might think about doing that is to block a number of these molecules, the JAK family of signaling molecules. And an example of that is using a drug called baricitinib, and there are a number of others. I think you probably hear about these every night on TV. They're advertised extensively. But here's data using baricitinib in type 1 diabetes, and that also had an effect on preserving beta cell function in patients with new onset disease. So I want to spend the rest of my time talking about this drug, teplizumab. So teplizumab is a drug that targets the epsilon chain on the CD3 molecule, which is the recognition molecule on a T lymphocyte. The CD3 epsilon chain is responsible for signaling after a T cell has recognized its antigen that's presented by MHC molecules. So it recognizes the epsilon chain on CD3. It delivers a partial agonist signal. We know, as I'm going to show you, it induces partial exhaustion of these cells, and that seems to explain its mechanism of action. So teplizumab is a humanized anti-CD3 epsilon monoclonal antibody. Now, I wanted to show this slide mostly for the house staff who may be in the room, and to make one point. So we began studies a while ago in mice and showed that an anti-CD3 antibody could change the course of the disease. The most important paper shown on the bottom here by Lucien Chateauneau and Jean-Francois Bax suggested that if you gave anti-CD3 to mice, NOD mice, with new onset type 1 diabetes, for 5 days only, you could reverse the disease, and the disease never came back. In other words, they had induced immune tolerance by a single short course of anti-CD3 antibody. But what I wanted to show you is the paper on the top that we did a few years before that, basically to make the point, and I hope there's house staff and fellows here, that about the date. We had studied anti-CD3 a few years later, but as you can see, that was more than 30 years ago. Now, the reason I want to point this out is if you are in the beginning of your career and you have an idea that you think is important and worth sticking with, it's important to stick with it in spite of what all the reviewers and what all the grant reviewers and all the paper reviewers say about your work. If you really believe that what you think is working, it's very important to stick with it, because I can assure you that there are a number of hurdles that need to be overcome in pursuing what you think is ultimately going to work. All right, so to summarize 30 years of work, let me just point out that we had done a number of studies in people with new onset type 1 diabetes, and it suggested that the anti-CD3 antibody would change the course of new onset type 1 diabetes. And so based on all the other work that I showed you, we asked whether, well, if we came in before the diagnosis of diabetes, could we prevent the disease from occurring or delay its occurrence? So this was a completely new paradigm, right? No one had really tried to prevent autoimmune diseases. And in fact, if you look, there have been a number of things that have been tested in type 1 diabetes, and none of them worked. And so we as TrialNet decided that we would give anti-CD3 antibody to individuals who had stage 2 diabetes. If you recall, I said that they have a 50% risk of developing type 1 diabetes, clinical type 1 diabetes, in 5 years. Now, and so we basically set up this randomized placebo-controlled trial. We identified people with stage 2 type 1 diabetes, relatives of patients with diabetes, but these people did not have diabetes. They did not take insulin. They did not follow a diet. The only reason we knew they were at risk is because we went looking for them. And we randomized them to drug or placebo. We gave them the drug for 14 days. This is important because there had been trials of other agents. I didn't show you all the other agents, like cyclosporin, azathioprine, prednisone, and so on, that needed to be given continuously for people with new onset diabetes. But this was different. This was 14 days of treatment and then stop. It was not continuous immune suppression, because continuous immune suppression, particularly for children, is a non-starter, particularly as the technologies for treating diabetes have improved. And so here's the consort diagram. We identified randomized 76 people. They're randomized to drug or placebo. They get treated for 14 days, and then we just follow them. And then we look for people who develop clinical type 1 diabetes, and then we ask, where are there more people in the drug or placebo groups, and when do they develop diabetes? It was a time to event analysis. So here's what the patients look like. They look like people who have type 1 diabetes, but they don't have type 1 diabetes. You can see that they have the HLA types of patients with diabetes, but their hemoglobin A1Cs are completely normal, and their C-peptides are pretty robust. As I mentioned, they are clinically silent, but we know about their risk of developing type 1 diabetes. So here's what the data look like. So indeed, the 2-week treatment of the drug delayed the onset of type 1 diabetes. Here's the data from the trial that was from the data 1 year after the primary endpoint. Basically showed that the diagnosis of diabetes was delayed out to about 6 years in patients who were treated with drug, compared to 2 years in the patients who were treated, 5 years in the patients treated with drug, compared to 2 years in the patients treated with placebo. Now, the other point I want to make from this is our ability to identify who's at risk is spot on. We predicted a 50% risk of diabetes in 2 years. That's exactly, essentially, what we saw here. Now, the C-peptide, the metabolic function, also improved with the drug. As you can see in the drug-treated people here in red, and compared to placebo in black, placebo declined after patients were enrolled, but the drug-treated people improved after they got the drug. Here are the adverse events. These were adverse events that we had seen in the patients with new onset diabetes who were treated with the drug. There are things like a decline in the number of circulating lymphocytes that I'll tell you about in just a moment. Some people developed a rash. There are other events that were occurring when the drug is given during the 14 days, but there was no difference in the adverse events after the drug was given. And the drug is no longer detectable on the surfaces of lymphocytes after about 4 weeks. Here's what happens to T cells when this anti-T cell antibody is given. The cells decline, and then the cells come right back. You can see on the x-axis, we're looking at the 14 days that the drug was given. And even while the drug is being given, T cells are recovering. We do not think that the drug causes depletion of T cells. This is not ATG, this is not CAMPATH, this is not even OKT3. Cells go down, cells come back. Our thinking about this is that the cells are activated in vivo, partially activated, and they leave the circulation and then will come back. Now, as a result of that activation, we have found that there are signs of exhaustion in the CD8 T cell pool. This was identified by work that we had done on the initial studies and then later by my colleague Peter Lindsley and Alice Long, and it was identified by the expression of molecules including EOMs, TIGIT, and KLRG1, sometimes PD1, on T lymphocytes. And the flow data is shown on the left side in patients who are treated with the drug. You can see that there are these EOMs positive, TIGIT positive T cells on the far left. They also express KLRG1, and some of them express PD1. The appearance of these cells, which is shown on the top right, in blue in the drug-treated people, you can see they increase by about 6 months after the drug is given, and then they decline afterwards. And we know that these cells make less cytokines like gamma interferon and TNF, because if you pull them out of patients and stimulate them, the drug-treated people, which is shown with teplizumab here, make less TNF and interferon gamma compared to placebo. Signs of exhaustion. We know that exhaustion is important in clinical responses. And I just want to remind you of this phenomenon that perhaps you've seen as well, which is that if you reverse exhaustion in T cells, for example, in patients with cancer with anti-PD1 or other checkpoint inhibitors, you can induce autoimmune diseases. This is our description, our initial description of checkpoint inhibitor diabetes in patients who had gotten anti-PD1 or anti-PD-L1 antibodies. These are patients with cancer, and these are older patients than we see who develop spontaneous type 1 diabetes, and they may present with diabetic ketoacidosis. If we look at the appearance of the disease, it's very rapid after the checkpoint inhibitor is given. Here's data. We're looking at glucose logs from patients who are given the checkpoint inhibitors, and you can see that there's a rapid rise in their glucoses, and their C-peptide levels shown in this graph decline very rapidly as well. Checkpoint inhibitors relieve the T cell exhaustion that I showed you was induced with anti-CD3 antibody. So we have flip sides of the same coin here. By inducing exhaustion in CD8 T cells, we can delay or prevent the onset of diabetes. By relieving exhaustion or reversing exhaustion, we can induce autoimmune diseases. And I'm sure many of you are familiar with other autoimmune manifestations of checkpoint inhibitors. Now, as the data from all the trials that had gone on in type 1 diabetes was done, and basically what it showed is that there was very consistent results across clinical trials. The C-peptide responses now in a few hundred people are improved with drug treatment on the left, and in people who are taking insulin, new onset diabetes, their requirements for insulin are reduced on the right side across multiple trials. Now, the FDA liked this and ended up approving the drug for the delay of type 1 diabetes. And of course, we were quite excited about this as well, because this was the first drug to change the course of type 1 diabetes since the approval, since the discovery of insulin 100 years ago. Now, just sort of as a note added and proof, afterwards, last fall, this paper appeared, which showed a phase 3 trial of the same drug in people with new onset diabetes. And let me just go through this data fairly quickly, but basically it's going to show you the same thing that I've told you about already. Here's what the patients look like. These are people with new onset type 1 diabetes. They're largely children. But the difference is their hemoglobin A1Cs on the right side are in the diabetic range. They have new onset diabetes. And C-peptide on the top left here is improved. It's statistically significantly improved. And if you look on the right side, patients who have clinically significant C-peptide, a level of at least 0.2 picomoles per ml that we know is associated with reduced risk of secondary end-organ complications like kidney disease, eye disease. The frequency of those individuals was improved with the teplizumab treatment. Now, in this trial, compared to the original trials that I had done more than 20 years ago, technologies had improved, and we were better able to treat the metabolic disturbances of type 1 diabetes. And so the investigators were told to treat to target hemoglobin A1C, and they did that. As you can see on the left side, the hemoglobin A1Cs here are matched in the drug and the placebo group, but the insulin that's necessary to achieve that same hemoglobin A1C on the right side is significantly less with teplizumab treatment. And consistent with what I told you earlier, the reduced requirement for exogenous insulin resulted in less severe hypoglycemia. Now, the rates of severe hypoglycemia are shown on the right side, but they were significantly less in the drug-treated people. And the level 2, less severe hypoglycemia, was also reduced with teplizumab treatment. The safety was what we had seen previously, and just to sort of summarize it, there was nothing exciting here. And unfortunately, COVID happened during this trial, and about a quarter of the patients in the drug-treated group developed COVID, and about a quarter of the patients in the placebo group developed COVID. But the outcomes of COVID were the same in the drug and the placebo-treated groups. And the same goes for other infections. So to summarize what I told you, type 1 diabetes is a chronic autoimmune disease with a metabolic outcome. We can identify who will develop the disease before the clinical diagnosis by the presence of autoantibodies and progression with impairment in beta cell function. A number of agents have been able to change the course of the disease at the time of diagnosis. Teplizumab is now approved to delay the onset of diabetes in those at risk, and we can give it safely to children and adults. It appears to induce exhaustion of CD8 positive T cells. And as I'll tell you in just a moment, some people appear to acquire tolerance. There are changes in CD8 positive cells that correlate with the immunologic function of the drug. Now, we think this is quite significant clinically because, as I mentioned, it's the first drug that can be used to delay the onset of, in fact, any autoimmune disease, and particularly type 1 diabetes. And the reason we think this is important, and you might say, well, 2 years, 3 years, what's the big deal? Maybe people are going to develop disease anyway. And I would tell you that in light of the burden of the disease that's present with you literally in every single thing you do, anytime, I think families will tell you anytime without type 1 diabetes is a gift. And particularly for children and their families, who were the majority of patients who we treated. I always like to tell the story about when I was at Columbia, at the Berry Center, there was a diabetes educator who I'm sure many of you know him, who had type 1 diabetes. And, we would sort of joke at that time, what are we going to do if we prevent or reverse diabetes? What are we going to do? And so this colleague of mine told me, he said, well, of course, now this is up at 186 and Broadway at St. Nicholas. And, if you look out the window, there's a strip of grass there that, of course, in New York is called a park. And then there's a bench in the park that looks out over all the traffic on Broadway. So my colleague said, you know what I'm going to do? I'm going to go to that bench, and I'm going to sit in that bench, and I'm going to do nothing. I'm not going to worry about what I ate, what activity I did to get here, where my blood sugar is going, where it was, what I'm going to do next. I'm just going to sit there and do nothing. And I think that kind of typifies what life is like with type 1 diabetes. It is never gone. It affects literally everything that you do. So now the other question, of course, is, well, in view of these effects, maybe we could enhance on this. Maybe we should combine it with other drugs. And I agree with you. That's exactly what we need to be thinking about doing. Let me just point out a couple last comments. Some of the patients have gone for a very long time without type 1 diabetes. What I've shown you here is the follow-up data, and the median time to developing diabetes is shown in the vertical dotted line here. And there are some people who have gone for even a decade without diabetes. Some of the patients were 10 years old. They grew up, they went to college, they got married and everything. They didn't have diabetes. Delaying the onset has a number of benefits, including, of course, the time without diabetes, the maturity of the patient, the development of technologies and other agents to change the course of the disease. So I would call this operational tolerance. Now, in terms of where we're going in the field, let me remind you of where we were in the checkpoint inhibitor field in cancer about a decade ago. We started with drugs like anti-CTLA-4 in melanoma, shown on the left side here. And some people had a good response, and some people had really good responses and went a long period of time. But we added drugs, and now all of a sudden, the frequency of responses improved greatly, and the duration of the responses improved greatly. I think where we are now is where those long-term responders were back, at the beginning of the checkpoint inhibitor field more than a decade ago. So how would I put teplizumab into clinical practice? So I think if you're a relative of someone with type 1 diabetes, you ought to be screened for risk of diabetes, because there is something that we can do to delay the onset of diabetes that I think has clinical significance. And I would broaden the inclusion of who I might screen to include people with other autoimmune diseases, people who have celiac disease, for example, and potentially others. And we can talk maybe in the discussion as to whether we should think about screening the general population. Where the drug is not approved, but where we might develop things is for people with new onset diabetes, perhaps with a combination of agent, or perhaps even by replacing beta cells that are lost by immunologic destruction. Now, there's no evidence that I know of that you spontaneously regenerate beta cells, but there's been tremendous advancements in our ability to grow and develop beta cells, even from stem cells. So I can envision in the future where you might give a drug like teplizumab or potentially others to patients with new onset diabetes, perhaps in combination with replacing beta cells. Now, as I mentioned, I'm the chair of TrialNet. So TrialNet is a consortium that is set up to identify therapies that will delay or prevent type 1 diabetes. So if you have families of where there's someone with diabetes, even extended families, I would encourage you to refer them for screening or even do the screening yourself. And if they're positive, there are therapies that and trials that they may be interested in participating in. Our goal, of course, is to build on these achievements and eliminate the disease entirely sometime within our lifetime. So let me just stop there. I want to thank a number of individuals from my lab who did the work, including those on the left side. I didn't go through all the mechanistic work that we have going on. I want to thank my colleagues at the University of South Florida, which is the coordinating center for TrialNet, my colleagues at UCSF that have collaborated on the checkpoint-induced diabetes, and lastly, our funders. So I will stop there, and hopefully I've left some time for questions.
Thank you very much, Dr. Herold. This was wonderful, and we truly appreciate your contributions to the science of type 1 diabetes. I want to start by thanking the Eli Friedman family for giving us this session every year to present something very unique in type 1 diabetes or kidney disease. So let's give a hand of applause to the family. Okay, so now it's open to questions. So let's give the chief of endocrinology the first shot. Dr. Marianne Banerjee.
So good morning, and thank you very much for joining us.
Louder.
Thank you very much for joining us today and educating us. The fellows are listening remotely this morning, and some of them are already in clinic. But I wanted to ask you this, and that is there any... Would it be useful to treat patients now who just developed diabetes, type 1 diabetes, with the hopes and with multiple intermittent refresher courses of your drug?
Yeah.
And how would you determine who needed a refresher course?
Yeah. So that's an excellent question. And let me just first start by saying the drug is not FDA approved for new onset disease. It's approved for people at risk. But to your question, all of the data that led to the approval of the drug came from patients with new onset diabetes, except for the one relatively small prevention trial. So the answer is that it absolutely has effects on preserving beta cell function in people with new onset diabetes. Now, then the next question is, well, maybe you should give the drug again. And you're right, that's the obvious thing to do. And in the new onset trials, the drug actually was given more than once. In the PROTECT trial that I showed you, the drug was given twice, at new onset and again at 6 months. Now, whether you can repeatedly come in with this and maintain the efficacy, I don't know the answer to that. That needs to be addressed in further clinical studies. And, there's a clinical study that's about to begin. The other possibility, though, that I would not rule out is coming in with an agent that targets, the key mechanisms that maintains tolerance to sustain the efficacy of the drug. So, basically a lot of hand waving at this point. I think what you're saying is exactly what needs to be developed.
Okay, thank you.
Thank you.
Dr. Robert Faronji is the Chief of Pulmonary and Critical Care Medicine.
Great. Thank you for that wonderful lecture. I think it really honored Dr. Friedman and the legacy of the Friedman family. The question I had was related to a comment that you made about innate lymphoid cells. Now, those cells don't express CD3. Do you think that combining this approach with something like Tespire would further augment the efficacy of this approach to prevent diabetes?
So let me just answer that with a yes, although I think we need to do the I think we need to, start with I would suggest the animal studies to look at the efficacy. Let me just sort of put the question in a different context. So we know, and this is largely work from my colleague, John Sang and others, when you have an immune disturbance, like anti-CD3, right? It targets a particular arm of the immune response, but it has effects on many, many different other cells. And in addition, the development of diabetes is not just a rogue T cell that then goes and kills the beta cells. There's a whole family that's involved in its pathogenesis, and they would include the innate cells that are resident in the pancreas, I truly believe, and other cells that may be resident in the draining lymph nodes and even other places. So I think to your point, that is exactly the type of work that we need, the type of studies we need to be doing to address the mechanisms of the drug and also the mechanisms of disease that may identify a second target for treatment.
Thank you very much. I see Dr. Amy Friedman, daughter of Dr. Friedman. She's a transplant surgeon. She has a hand up. Actually, she was a surgeon also at Yale University. She was one of their transplant surgeons at Yale University as well. So you may recognize her name. Okay, Dr. Friedman.
I just really wanted to say thank you very much to everybody, especially to Dr. Salafu for doing such a lovely introduction. Just for anybody who's not aware, Dr. Eli Friedman is not, he is alive. He's not well, but he is alive still. And I wanted to really thank you for such a wonderful, wonderful lecture today, inspiring. And let me just, two things. One of their grandchildren is listening to the lecture today as well, which I'm very proud to say. So my question is, if you were a grandchild of the Friedmans, and let's say your A1C was not completely normal, but your BMI is reasonable and everything, within the context of current insurance coverage, etc., what would be the first couple of steps you would take?
Let me thank you and the Friedman family for the honor to give this talk. I mean, it's inspirational, actually, to be able to do it. So the answer to your question is, I would screen for autoantibodies, and then if the glucose is creeping, or if there's anything, the hemoglobin A1C, I would, even if the A1C was completely normal, I would do a glucose tolerance test and see where things are. If there is some impairment in the glucose, there's some details that differ between what the ADA calls stage 2 and what we in TrialNet have called stage 2. But if there are two positive autoantibodies and something about the glucose tolerance test, quite frankly, I would take the drug.
Okay.
Thank you.
Thank you very much, Dr. Friedman, for the question. I'll be visiting very soon to see Dr. Friedman, and I'm always happy to come and visit. There are questions in the chat box. I want to address them quickly. The first one says, how many children need to be screened to identify one that could benefit from antibody therapy?
Well, of course, it depends on whether you're talking about the general population or those or relatives. Now, the relatives are enriched for people at risk for diabetes. The rates of diabetes are quite low in the general population. So, if you take a look at the German data, the Bavaria data, they screened about 100,000 people and identified a couple hundred that were autoantibody positive. Most of them have two autoantibodies, normal glucose tolerance, but some of them had, some impairment in glucose tolerance. So that gives you kind of the, a couple hundred out of 100,000 is probably the best that you're going to do. For family members, the rates of diabetes are somewhere between 2 and 6%, right? So, the other reason, frankly, that I tell families to screen is there's a good chance it's going to come back negative. And if it's negative, your risk of developing diabetes over the next 10 years is no different than the autoantibodies. It's no different than the background population. So those are kind of the numbers. What some groups have done to improve the efficiency of screening is to screen individuals who have the high-risk HLA types or the high-risk, you can get a gene chip now for about $10. You can identify those who have high-risk genes and then screen them. So I hope that answers the question.
The next one has to do with, can the 14-day run of immunosuppressive therapy be repeated at intervals?
Yes, the answer is yes, except there's one problem I have with your question, which is we have not called it immune modulation. And the reason for that is this is not the same as steroids, azathioprine, prednisone, and the other drugs, and it is not chronic immune suppression. So it causes changes in immune cells acutely, but then afterwards, we don't see really changes in immune function.
The next question has to do with malignancy, long-term risk of malignancy.
Yeah, so this is, of course, is the issue that brings us up, keeps us up at night. But let me explain, let me give you our rationale. So first of all, the drug's given for 2 weeks. It is not chronic. And the drug is gone off the surfaces of T cells after about a month. The cells that will be responsible for destroying cancers and cancer surveillance when you're 50 years old are probably not the same cells that are causing diabetes when you're 15 years old. And so the only cells that are affected by this treatment, in theory, are the cells that are present when the drug is given. So we haven't seen it, of course, and I would say it's probably less immune suppressive than something like chronic steroids.
Okay, thank you. I think since I'm the chair, I can ask one question. And also I'm a transplant nephrologist, so I want to ask one immunology question. So I didn't hear much about memory B cells. For instance, approaching the suppression of memory B cells using the proteasome inhibitors and that kind of stuff. Is there any data in that area to really suppress those cells hiding the antibody?
Yeah, a good question, and no, that I know of, except I would point out that one of the problems that we had with rituximab is that we didn't suppress any memory B cells, and reactive B cells that they come right back after rituximab. And I would also, I'm just quite keen on this, highlight the work of George Schett from Germany, in which they've done profound B cell depletion and shown that in patients with other autoimmune diseases, they can in fact induce tolerance. So I think that your question is an important one for where we should go in the field. And we haven't done it yet.
Okay. All right, it's exactly 9:30, and you give us time to ask questions, so thank you very much. So all of you, please join me in thanking Dr. Herold for a wonderful lecture and contributions to science.
Thank you very much.
Thank you, and have a good day. Thank you.
You too.